Hi, everyone, and welcome to this weekly edition of What's Up, Doc. Today we have vascular surgeon Juan Carlos Correa from Kansas City. He is here with us to answer your questions. We've gotten quite a few in over the past week in excitement for Dr. Correa coming in today to answer questions in our weekly sessions. So thank you so much for taking time out to join us. I know you're busy, you know, doing your dictations in clinic, from facility to what you have an office-based lab and you go to the hospital as well.
Yes, I do. Yes, I do. And thanks for having me here, Kim. This is fantastic.
What is the number one question that you always get asked from your patients over and over again?
Oh, I would say the main one is there a cure? Is there a
Mhm.
cure for my peripheral vascular disease? Is there any magical pill I can take? Or after you do this procedure, am I good? Is this it? Is this the last time I'm going to have one of these issues? And it's hard to describe that to patients where I tell them, imagine that there is a cancer inside your arteries. And my job is to put it into remission so that your symptoms get better or you prevent you from, heaven forbid, lose a leg or have a stroke. Um, but the disease is always there. Now, we do have a bunch of great medicines that we can use to kind of slow down the progression of the disease, but the disease is there. But I would say that's the main thing that patients ask. When am I going to be finally cured of this? When can we stop doing ultrasounds? When can I stop taking my statins? When can I stop taking my aspirin or my low dose Xarelto? When can I stop doing this? Short answer is, well, you can't. You have a lifelong disease and we have to be on top of things.
Partners need to be Patients need to be great partners in their own care. You can only do so much as a doctor. You can get that into remission, right? But it's up to the patient to keep it in remission by being compliant with those medications. But also, the best medicine of all is walking, but not just any walking. How do you walk effectively to grow those beautiful collateral vessels, or what are known as natural bypasses, around the blocked arteries in the
That
legs?
that is a great question, Kim. So first of all, when we have patients who claudicate, which means that it hurts when they walk, when it hurts when they walk. If this is the femoral artery, that's at the level of the middle of the thigh, if that artery is the one that has this disease, growing those collaterals requires, just as you said, walking. It is essential, but it requires, just like going to the gym, you have to do this every single day. And you don't do it because you did it for 15 minutes. Muhammad Ali, they used to ask him, how many abs do you do? And he would say, well, I don't start counting until it hurts. And we should apply the same thing when we're walking. It's not a matter of going out and walking 15, 20 minutes a day at the indoor mall that's local. It's actually walking through to where your legs ache. And then when they ache, pushing, if you can, maybe another half block or another block, and then taking a break and doing that 3 or 4 times consecutively. And that will help grow those collaterals. But it's not about time. People say, oh, I walk 45 minutes twice a day. But you watch them walk and you're like, no, that doesn't count. You're barely walking. You're window shopping. That doesn't count.
We have patients that will call us and say, but I've been walking, I don't understand. I mean, I walk 1 to 2 miles every single day. I've been doing this for 15 years. And then suddenly my legs start hurting. That doesn't make sense, but that my doctor now wants me to walk. I don't get it. And the doctors are not teaching their patients exactly what you said, that it's not just about going out and just leisurely walking. It's about pushing yourself, just as you do at the gym, like you were saying, give me that one extra rep, give me that one extra rep. You're not going to grow that bicep. You're not going to get those muscles unless you push that extra rep. And that is such a great way to think about it, that when you're walking, you're not going to push it. You're not going to build those collateral vessels until you push through that pain.
Yes. Yes. Absolutely.
And so it's still tough, though, to convince your patients to push through that pain, isn't it?
So the tricky thing is, um, some patients they develop a more sudden development of that femoral artery disease. So it's harder for them to grow collaterals because they have nothing's even possibly being built up. And that's where the possibility of adding medications could help. Now we do have medications that, in theory, um, can help blood squeak its way through these smaller arteries collateral. So we've got low dose aspirin, we have low dose Xarelto, we have the classic medicines that started in the 70s and the 80s, Fleetol and Trentol, which are the first line therapy for patients who have purely claudication. And there is pretty good evidence that the combination of these will help that patient be able to walk, hurt, and be able to walk through it. But sometimes you have to hold their hand in that process. I can't just tell them, well, go walk, but here's a walking program, a 12-week walking program, and we're going to try these medications. And if they don't work, we're going to escalate these medications. And if that doesn't work, well, then maybe we consider some type of therapy, more invasive therapy. But
What
it does require lots of hand holding. Yep.
what are the indications for a vasodilator such as silostazol or Platal?
So the American Heart Association, Society of Vascular Surgery, the American College of Cardiology recommends um, Fleetol as first line therapy, in the absence of severe congestive heart failure. And that patient that comes that says, you know what, my calf hurts. I used to be able to walk, just like you said, 1 or 2 miles a day. And you know what? I can't even make it to the mailbox and back. It would be considered that that is first line therapy in combination, with that secondary treatment of all the risk factors, where the aspirin, the ACE inhibitors, the statins, the smoking cessation, all of those things play a role. And you have to combine them. You have to combine them. But that's exactly where they play in.
We got a question earlier this week from a patient that was asking about endarterectomies. I know this is quite the jump, but I wanted to make sure that we get in
Okay.
some of the questions before we're short on time today for this one. But endarterectomies, the doctor went in and had a failed angiogram. The common femoral artery was too far blocked, couldn't get a wire through. And so the doctor said, next step is an endarterectomy. So he wants to know, what is an endarterectomy? What can he expect? Any complications he should be aware of, and critical questions to ask his doctor before going into the procedure.
Okay, fantastic. This is a great question. So at the level of the groin, we have the common femoral artery at the level of the groin. And this artery does not respond very well to treatments that are endovascular. The big one is a stent. We cannot stent this artery. As vascular surgeons, this is a big no-no, just because the data on doing an endarterectomy, and I'll explain what it is so robust and still great. An endarterectomy is where you make an incision with the patient completely asleep. This is a hospital-based procedure. You cannot do this in the office or in a surgery center. With the patient completely asleep, we make a longitudinal incision in the groin. And what we're going to do is we're going to open up that femoral artery. And in the process of opening up that femoral artery, we use a series of, they look like small spoons, small knives. We're going to scoop out all of that plaque of that artery, all of it. And by doing so, we're going to basically open up that artery, get all the plaque out, and instead of suturing it back together again, we're going to put a big fat patch on top of it. That's the patch angioplasty that we put on top of the artery. And the reason why we do it is because everybody scars. Everybody scars. So if I make it almost double in size and it scars over the next 10 years, it's going to go back down to the same size it was initially. And making it bigger actually helps that patient get significant resolution. Procedure takes about 1 to 2 hours to do. There is a backup in case that endarterectomy is too extensive. You're like, oh my goodness, I've got plaque from the iliac artery down into the profunda, down into the femoral artery. What am I going to do here? This is very difficult. In which, as vascular surgeons, we also have to be trained in doing a bypass, where we're like, you know what? I'm going to abandon an endarterectomy. This is too extensive. And I'm going to connect the iliac artery to the femoral artery and the profunda. It's a bigger operation, but still takes about 1 to 2 hours. The majority of patients spend one night in the hospital. Majority of patients. On my patients, I prescribe them with narcotics. Majority of don't even need it because I try to make small incisions. And then over the next 4 to 6 weeks, what can they expect? Well, the biggest one is a lot of times that calf pain and foot pain already gets better. This is the main artery going down their leg. Second thing that can happen, and happens, I would say, in about half of patients, is they end up with a swollen foot. And they're going to say, Doc, You did the surgery to me, and now I have a swollen foot. And that's because there's a lot more blood flow going down. And because there's a lot more blood flow going down, those veins aren't ready to send all that blood flow back up yet. So you end up with a swollen foot, and that is normal. It goes away in about 4 to 6 weeks. And for that, the treatment is elevate the leg and walk. And now that you can walk, we absolutely are going to encourage it. Absolutely. The biggest complication that we can get from a femoral endarterectomy is an infection. That is the number one complication. Now, it is a very slow number. It is a very small number. We're talking less than 5 to maybe 7%, because you're in the groin. And in the groin, it's a nidus for all types of bacteria and yeast that can be there. And that's the biggest risk that you can have. And a growing incision that gets infected, they're very difficult to treat. Sometimes it does require a prolonged hospital stay. That's where we do debridements, where we have to clean it up, maybe put on a wound vac. But that's the biggest complication. And then the failure rate in which you do an endarterectomy and you know what, it didn't work, is less than 10% at 8 years. And that is one of the biggest series for endarterectomies, which if you look at that data, that's really, really impressive for vascular surgery data.
I think so too. It's always been for us the gold standards. We always suggest that a patient go in and have an angiogram no matter what first, because there's limitations to what a 2D image can tell you, what the CT angiogram can actually
Yeah.
tell you. I like for the doctor to go in and actually check out the morphology of the plaque and really see what's happening there, especially sending in intravascular ultrasound, just an extra set of eyes, to get a better idea even of the sizing of the vessel, even if they do nothing, just to go in
Yeah.
there, take the wire and check it out, right?
Yes. Yes. Absolutely.
Now, when
Or
you're
a good
doing
CT scan also. Yes.
good CT angiogram, that'll
Yes.
do it for you.
Well, also I'm a big fan. If I stick you, I fix you. So if I know that I have somebody with severe common femoral artery disease, do I really want to put them through the risk of a procedure in which I'm just going to take pictures? That patient, absolutely. I might just go ahead and get a CT angio and then figure out a game plan. And if it's not enough, then I'll do the angio.
Yep, good point. And you mentioned the potential for bypass, and when
Yes.
when a patient goes in for the endarterectomy, should they be prepared for a potential bypass? And just in case, even if the doctor doesn't talk about it, should they ask the doctor, hey, what happens if you go in there and it's a little bit more robust plaque than you realize? Like, what is the contingency plan?
Yes, that's absolutely a question that you have to ask your vascular surgeon. What if, just like you said, what if you go in there? This happened to me yesterday during an endarterectomy. I had to use a patch, and then I had to open up a second patch and use half of that one because there was just so much disease. But what happens if you go in there and maybe somebody already did an endarterectomy, or they had some type of atherectomy angioplasty and the damage was so extensive that you cannot repair this artery? You have to ask your surgeon, what is your backup? And if this doesn't work, what is your backup? Well, if you can't connect it to the femoral artery, how are we going to fix it? I would say for vascular surgeons, we also always have to tell patients there is that possibility that we might have to do a bypass. Now, the risk is very low, but you have to have the conversation.
And in those types of bypasses, in those situations, usually when you have a patient and you say, okay, we're going to prepare for bypass, they do vein mapping and they talk about using, your own vein, right, for that.
Yes.
What happens in those situations, such as, you said, even with a recent patient of yours, what happens if you end up with a bypass and you didn't do all of that prior to? What is the direction you go with this bypass?
Um, that's tricky because that's part of the due diligence. You have to be, be ready for the worst every time you go in there. It's part of the job. There's always, if you didn't do vein mapping, there's always that possibility that you could explore the vein, make an incision and make a dissection and see what you can find. And I will say the majority of the time, we do find suitable veins. But what happens if that patient already had open heart surgery and that was the leg that they took the vein from? Now, what are you going to do? Are you going to risk the other leg by taking that vein, or are you going to use a piece of plastic for a bypass? All of these are those contingencies that you had to be ready before you took that patient to surgery.
Mhm. And we do have a patient that is writing in on YouTube. She wants to know when it's time for a bypass. She's going on her sixth atherectomy. I don't know the time frame though. The last one was in May, and oh well, here we go, less than a month, and now she is blocked again.
So I will say there's no absolute number for this. Again, as vascular surgeons, sometimes you're taught, well, if you do it once and it fails, you have to think about something else. But there's where the other what other medical issues might be going on. Is this patient still a smoker? Is this a patient who might be on the wrong medications or doesn't take them the way that they should? Is their diabetes completely out of control? All of those things need to be considered because doing a bypass carries significant risk also. Because if you do a bypass, and as vascular surgeons, I always leave a back door to still be able to open it up with wires and catheters and stents in case my bypass goes down. But I have encountered times in which somebody goes in for a bypass and they figure, well, the SFA is bad artery. It's completely clogged, and they will literally cut the artery and disconnect it from the common femoral artery and then plug it in the bypass. And when the bypass goes down, the only option you have is to redo the bypass because they
Yep.
tied off the femoral artery.
And that's even what I say when a patient even is going back for a second atherectomy or angioplasty or overall angiogram, I always say, well, why are you going back? What's going on? Can we look at those risk factors before we put you back in for the procedure, before it just goes in and reblocks again and again, unless it's a few years, right? Unless you have a few years in between and then you kind of know maybe some scar tissue is in there. But we've had so many patients that have ended up with undiagnosed genetic mutations. We've had patients that have had undiagnosed clotting disorders. We've had patients on Plavix that had a sensitivity to it, and so it wasn't working in their body. And especially ones that have had it where it was with they had it paired with a statin that I guess they both couldn't fit on the same school bus. Dr. Anita Dubois, as you know, a vascular surgeon, she came out with a study recently that talked about that.
Yes.
And
Yes.
so there are things but I don't understand how the doctors do not stop for a moment to consider this, to say, hey, wait a minute, before we put you back under the knife, let's stop and let's take a revisit at I mean, this could have just been chance, but why take the chance without dotting your I's, crossing your T's first? And that's what I
Yes.
tell patients before you go in there with this checklist that says, okay, do I have an autoimmune condition that's out of control? Are my medications okay? Am I compliant with those medications? Am I walking? Let's make sure that we exhaust all of those first before we put you back on the table.
Yes. Now, that being said, being a devil's advocate on this, the smaller the artery, the higher chance endovascular treatments will fail. That's in layman's terms, that's what we
Right.
have. The
Below the
next
knee,
part of
right?
it, yes, absolutely, for tibial interventions. The next part of this is even in the best endovascular treatments of, for example, the femoral artery, there's not a single treatment, there is not a single treatment that is 100% at 1 year. Not a single one. Which means that 1 year, you probably have a 95% chance of the stent needs to be revised. They might need to increase your blood thinners. They might have to put you through another supervised walking program. Something else is going to happen. So there's also that. Let's be realistic with this. A bypass, yes, it has much less reinterventions. Absolutely. It also carries a lot of risk, especially in somebody's hands who does not have experience doing a lot of bypasses.
Yep. And I think in this patient's case, she says that she was blocked in the thigh and the femoral. So that's something you were mentioning even a little bit earlier, where there is that bypass. You can go just from the iliac to the lower end of the thigh, right, just
Yes.
before the popliteal, and you can go ahead. And those are pretty durable from what I've seen.
Yes, above the knee fempop bypasses have a very good patency rate with a vein, very good patency rate. And
Hmm.
even with a piece of plastic at 5 years, you're still talking about 75 to 80% primary patency.
And there's still a contingency plan beyond that. I mean, you have the backup, even with most
Correct.
of those. Yeah. And
Correct.
so that's really good. But always, as you said, and I think this is really great advice, everyone, is as Dr. Correa says, make sure in every situation that your doctor has the backup plan. What happens? It's not if it's going to fail, it's a matter of when. how long do you think? And then what is the backup plan at that point? Always have the contingency plan. With that being said,
Yes.
we have Alan who's here. Alan has a question. Go ahead and unmute and ask Dr. Correa your question.
Hi, doctor. How are you?
Hello there.
I'm a left BKA, below knee amputation.
I'm
And
sorry to hear that, Alan.
short, well, I'm still alive. I'm still going. Kim keeps me young. And
I'm a
I'm
pain.
where other people are fighting to keep their legs, I'm fighting to keep my residual limb. One of the common things that happens is after a BKA is if you have a bypass, synthetic bypass, a FEMPOP, and they can't reopen the common femoral, it has a tendency to block up because the blood has nowhere to go downstream.
Yeah.
So I had disease also in my deep femoral artery, the profunda. And
Yes.
the doctor was trying to do a endarterectomy, could not do it because I've had so many surgeries. I'm at like 10 in the groin area.
Goodness.
And so I had so much scar tissue that the control, what do you call it, nerve was plastered to the side of the deep femoral artery. So he had to do a 2-inch bypass with synthetic, and it seems to be okay. It's warm, no problems. The flow rate is around 215. It is a little turbulent.
Yes.
What is an average lifespan for something like that?
So a short bypass with
2 inches.
good endpoints is a very good patency rate. If you're saying it's just a 2 centimeter bypass, tricky thing is it's a piece of plastic, but still a short bypass that has a very good patency rate. And doing a common femoral to profunda artery bypass, in theory, the profunda is a very low resistance system. It should have a high patency rate.
Okay, thank you very much.
Oh, you're
We have
welcome.
Marcia.
Welcome. That's a tough case. Oh man.
I know.
I'll come down to see you when I'm ready.
Oh no, not for surgery number 11, please no.
He likes the first ones.
Yes.
Marcia has a question for Dr. Correa. Marcia, go ahead and unmute and ask Dr. Correa your question.
Hi. Thank you, doctor, for being here.
You're welcome.
I have a question. So my SFA is completely blocked and I have a full metal jacket. Is that what they call it?
Yes, that's a lot of
Yes.
sense. Yes.
Yeah. So, and I'm doing really well considering, but behind my knee, sort of like when I'm driving, I kind of am getting a pain, or when I sit. And lately when I'm walking, I am. And I never had pain before, and I don't know exactly where the stents are, 100%. But I'm wondering, can they move? Can they slide down? Because why would I have, like, it's almost like I can feel the stent now, is what I'm trying to describe. It's not pain like, well, I have claudication, but that's not what I'm actually feeling something there.
Yes. So the short answer is, yes, you can feel a stent. Now, imagine when you're standing straight or when you're lying on the cath lab table, your femoral artery, it's not completely straight. We're looking at it, just as Kim said, in two dimensions, but actually it comes down from your groin and is this lazy F as it makes its way into the popliteal artery. Now, when it makes that lazy F and you put a stent, the stent takes that form. But when you bend your leg above the knee, the whole artery bends up. And if you put a stent that's very stiff, that stent kind of tries to stick out through the artery, and that is what you feel. Now, there are different types of stents that are a lot more flexible.
Does that signify a problem? That it's been a year since I've had my stent, all of them. And I never had any, sorry, somebody sending me stuff. And I've never had this sensation until like in the last 3 weeks. So is that usual, or is it something to be concerned about?
I think it'd be warranted to get an ultrasound to start making sure
and I'm
that
due
just
anyway.
beyond that stent, there's not a buildup of plaque because that's what tends to happen after the stents. We have more buildup of plaque. It has to do with the flow. And if that's causing a problem, or it has the stent itself, because you go up and down, stents can fracture. It can fracture. It's been described in every single stent can fracture.
Oh gosh. Okay. All right. That's scary.
Well,
All right.
but
Thank you.
they don't go down your leg. They could fracture inside the artery. And if we really zoom in when we're doing the angiography, we can see that the struts of the stent, they basically came off a little bit. And that's something that we keep an eye on. We can always treat that.
Should I, because I am due, for my ultrasounds in about, I don't know, 2 weeks or something. Should I let my doctor know in advance that that's something maybe they want to be looking extra hard at? Because,
Well, I would say
otherwise,
if you gave him the description that when you have your leg bent, you have the sensation of something pushing or that
right.
something in the back of your thigh or behind your knee, when you have your leg bent, not straight, that should automatically be that light bulb of, is that stent itself causing decreased mobility in that artery and the stent is, protruding or
Okay.
causing too much force there? Yes.
But I mean, it's something I should alert him to so that when I'm having the ultrasound, the stenographer, or whatever they're called, the
Yes.
ultrasound person is looking for that.
They could look for it. Now, the big thing that they're going to look for is after the stent, what does the flow look like? Is it turbulent? Just like Alan was saying, is it turbulent? Does it have very high flow, significant maybe stenosis right after it?
Oops. Oh,
Yep.
oh, you froze. But I mean, they're looking for that regardless, aren't they? Or would they look
Yes, every
extra hard
time.
if I alert my doctor? Okay.
They'll probably look extra hard if you tell them.
Okay.
Yep.
All right.
And
Thank
we
you.
have one more. Douglas has a couple questions in here. And I think we're going to go back to where we started in the conversation on walking. Douglas, go ahead and unmute and ask Dr.
Just
Correa your questions.
great to have you. Great to have you. This was brought up in the group. They were talking about growing collaterals. Can you grow collaterals in your feet, below the knee, above the knee, in your thigh, and like around your heart? One of the questions was, where do I grow my collaterals? Can I grow around the veins or the arteries?
Collaterals can grow in any part, and we can't predict where they're going to grow or how they're going to grow. We can't. What we do know is that supply and demand. The more you demand, your body in a healthy circumstance will try to supply. Will try. You can grow collaterals in your feet, in your calf, in your thigh, just like you do around your heart. Now, does this mean that those collaterals will suffice? No, no, but we have to at least try. We have to at least try to grow those collaterals. It's a good question. Good question.
And Douglas, your second question.
Well, I was going to ask, have you ever done an axial bifemoral bypass?
Yes, sir.
Do they still do those necessarily today, or is that I understand that there's something that they don't really do that much anymore?
No, it is still done. I would say the biggest setting in which it's done, and this is a fantastic question, by the way, in which we do an axilla, which means we go beneath your axilla, usually is on the right side, and we tunnel a bypass beneath, close to your skin by the rib cage, and we go to each femoral artery. The number one setting in which we do this is when there is an infected aorta. So we can't suture where there's an infection because the bacteria, they will eat our suture. So we have to go around it. Obviously, we could do nothing, but then you don't have circulation and you lose your legs. But by doing an axillobifem, that gives us time to give you the antibiotics to heal, treat that infection, and maintain circulation. That is, I would say, that one of the most common times in which currently we use an axillobifem bypass. That's a
I
very
have
good question.
one. I have one. It's totally blocked. Can't wear blue jeans. Can't ride a bike. Can't drive that long. Can't sit in the kayak because it pokes me. But I understand it's totally occluded.
They do not have a long lifespan. They do not. The longer the bypass, the higher chance it's going to fail. The longer the bypass, higher chance it's going to fail. But even if you did fail that, there are always contingencies. You can do an aortal bifem, which means we go into your belly and we reroute it, or we try to open up your native arteries if that's not a possibility.
What we always tell people is, I mean, unless there is an infection, that the axillary bifemoral bypass it's rarely done these days, and it's a Hail Mary. It's more palliative care is the way I've heard it described, for the
A lot
most
of
part,
times, yes. Yes.
because it is so temporary. We had a patient that actually ended up, she had a blocked aorta. It was known fresh clot because she forgot to take her meds for a few days, and they wanted to go straight to the axillary bifemoral bypass. I had talked them down from the ledge to do a thoracic, maybe because it could be more durable, but I said, why don't you go in? Why don't you do a TPA first? See if you could soften it up, at least go in. And it took us 4 days to convince the doctor. Well, he just left her sitting in the hospital bed, and I was calling the president of the HMO, and I was calling the vice president, and this one vascular surgeon who's the head of vascular surgery, wanting to kick the can down as far as he could. And I said, well, you're kicking the can down. Well, really not that far. No, they can last up to 7 years. I said, so what are you going to do with this 50-something-year-old lady after, in 7 years? You have no options for her. That clot's already dried up. You're not going to be able to go in the native vessels. What are you going to do with her? Well, it doesn't matter because that's the most durable thing that we can do right now. And I said, I think that we need to shift our way of thinking here on this one.
Oh, that's tricky. That's tricky. I
Very.
think
So
we all have something to learn, and there's where sharing experience, sharing knowledge, with experts in different fields, no matter the specialty, is the only way in which we move forward. It would be the only way. I was
exactly.
very lucky. I've always been very lucky that I've had I had amazing professors during my residency and fellowship, and then when I was in practice with a group, I had fantastic, more senior surgeons that I could bounce ideas off of. And that's critical. That's critical nowadays, because a lot of people, just as Alan said, they don't know how to do these types of bypasses. They have limited experience. Where sometimes those with more gray hairs, you can ask them like, "Oh, I've done, I don't know, about 50 of those. And let me share you my tips and tricks on how to do this."
Well, I know you have to run. We appreciate your time. Marcia just wants to have one more quickie here. What can be done if her stent is bent? What if it's fractured? Should she do something about it?
Short answer is yes. We know that there's a direct correlation with stent fractures and stent failure. Now, you can stent within a stent. That can be done. And there's where the consideration for more flexible stents plays a role. But it'd be difficult to see. Now, if Marcia is as mobile as she says she is, she would absolutely benefit from a more flexible stent. Absolutely. Absolutely.
Thank you. We really appreciate your time, Dr. Juan Carlos Correa. Appreciate you. If people are in the Kansas City area, where can they go to find out more information and come see you?
At kcvi.com, Kansas City Vascular Institute.com. Here's where you can find me and my amazing team. We're very proud of what we do and what we stand for, which is literally going the distance for the right patient to save their legs.
Thank you so much. And make sure, have a great day, Dr. Correa. We really appreciate your time, and everyone else who's on here. What's Up Doc is a regular series every single week. Make sure to remember that the advice and views offered are that of our guests on this program. Always, always, always check with your own healthcare team to get explicit consent before acting on any information provided here. And with that, have a great week, everyone.